could do those football guys every weekend.
Hey, how are you?
Thank you.
Thanks. Ron?
This is
Jeremy Nowak from the Reinvestment Project.
Oh, nice to see you. It's great to be here. Thank you.
Put some things out from you.
Better. Things are good right now. Things are good right now. We're on a roll. Well, it's funny. I'll be back here Monday. We got the Giants Redskins Monday night for a Monday night game, so I'm going to go back home today and come back Friday. So. Thank you.
Yeah.
Here's our little. Yeah. The subcommittee hearing will be called to order. And today's hearing is on innovations in addressing childhood obesity, and I'll recognize myself for an opening statement initially. The topic, innovations in addressing childhood obesity, is one of interest of many members of this committee and also members of the House. I have to say, we're having this hearing today because many members, including some that are not on the committee, have approached me on the floor and asked me to address this issue in various ways. Childhood obesity is a huge public health problem in this country that puts millions of American children at risk. Data from the Centers for Disease Control and Prevention, the CDC, indicates that over the last 3 decades, the rates of childhood obesity have been skyrocketing. In every age category, we have seen at least a doubling, and in some age groups, a tripling in the numbers of children who are classified as obese. In addition, there are millions more who are just at the cusp and are in danger of becoming obese as well. The rates are the worst among minority populations. According to the CDC, Hispanic boys and African American girls have the highest rates of obesity, with 22.1% of Hispanic boys and 27.7% of African American girls classified as obese. And though the rates are starting to level off, there are still too many children in this country who are dangerously overweight. Childhood obesity can lead to health problems that 30 years ago were rarely seen in children. A report conducted by the Trust for America's Health in 2009 highlighted that more and more children are being diagnosed with type 2 diabetes, hypertension, sleep apnea, joint problems, and depression, to name just a few. And I should say, for many years now, I've co-chaired, well, I haven't co-chaired, I've been the vice chair of the Native American Caucus. And when we go around and to the various reservations, I've just noticed in the 21 years that I've been in Congress that, you know, the rate, if you will, for type 2 diabetes and the number of people that have it, when we go around to the reservations, it just gets younger and younger every year, and it's really almost of an epidemic nature, in my opinion, amongst the Native American populations. And these children are likely to continue having health problems as they age into adulthood. Some experts have even predicted that if the trends in childhood obesity continue, we will for the first time see a generation that lives sicker and dies earlier than their parents. Regardless, we know that if left unaddressed, this epidemic alone has the potential to cripple our healthcare system. The price of obesity in this country is unsustainable. Adult obesity is estimated to cost our nation $147 billion per year, and childhood obesity adds another $14 billion to that price tag. Studies have shown that up to 80% of obese children will become obese adults, and as we watch the number of these obese children skyrocket, the cost to our nation will not only increase, but an obese and unhealthy nation may very well bring about an unproductive nation. In my state, New Jersey, 31% of our children are clinically overweight. That's nearly 7% higher than the rate of adult obesity. And I'm worried that at a time of economic recession and high unemployment rates, many of these children will be less likely to have access to healthier, more expensive foods. Meanwhile, safety net health programs are continuously overextended as the numbers of uninsured and underinsured continue to grow, posing further risk to children who may not be receiving the medical care that they need. There are many factors that contribute to our rising rates of obesity. Personal habits definitely play some part, but many studies have been able to link obesity to unsafe neighborhoods, less exercise opportunities, and lack of access to healthy foods. Our healthcare system also plays some part, with millions of children living without preventative health services such as nutrition counseling and screening for obesity-related diseases. These are all things that we as a nation can work together to address so that we can eventually reverse the trends of childhood obesity. And basically, we're holding the hearing today because we're trying to find out from our witnesses about innovative work they're doing to address childhood obesity, to hear about how we at the federal level can play a part in curbing this trend, and to learn more about what makes obesity interventions successful. And I am also eager to hear a bit about where we need to focus our efforts over the next 10 years. I'm not, suggesting to any of you that this is going to be something we're going to be able to solve overnight. I know it's something that needs long-term attention in many cases. I was thinking today about when I was growing up in the neighborhood. I don't live in the neighborhood anymore, but my father's still there, and our congressional office is in the same neighborhood where I grew up. And almost all the recreational opportunities that existed when I was a kid have disappeared. The local playground's not there anymore. They're just, the YMCA is not there anymore. And, we live in a small town of about 30,000 people. It's not an urban area per se. But, if you're going to bring back those things, it's not something you can do overnight, unfortunately. And I just think that we haven't paid enough attention to a lot of these underlying problems, whether it's recreation, whether it's food, whether it's supermarkets. And, these are not things that you can necessarily deal with immediately, but they have to be addressed. So thank you. Thank you for being here. We'll introduce the panel after the rest of the opening statements. And we have the gentleman from Georgia, Mr. Barrow. You'll wave. And next is the gentlewoman from Florida, Ms. Kaplan.
Thank you, Chairman Plum, very much for calling this important hearing. The good news is that over the past few years, the Congress has made wellness and healthy living and children's health a national priority. I mean, at the beginning of this year, the beginning of our agenda, the Congress passed and sent the children's health care legislation to the President for his signature. That expanded health services and medical care to millions of children all across America. And last month, the House version of the health care reform bill dedicated a huge part of the health reform effort to preventative care, wellness, and public health initiatives, really the most landmark investment in public health ever in the history of our country. And going back to the last Congress, in 2008, the Farm Bill required the USDA to purchase more fruits and vegetables for nutrition assistance programs, and created a new program to provide fresh fruits and vegetables to elementary schools. So all of that is very positive. But all of this is in recognition of the fact that obesity rates for both adults and children in the United States have increased exponentially. We now have a clear understanding that this is an issue we need to address head-on. There is a growing movement to live healthier lives and ensure that our children grow up with the same understanding. But I look at the statistics, Chairman Plone, like in my state, the children in Florida, 33% of children in Florida are overweight or obese. That's above the national average. And there's no excuse for this. This is the Sunshine State where you can play outside all year round. So Florida, like many states, Florida is trying to do some creative things. In my community in Tampa, the University of South Florida has developed the USF Healthy Weight Clinic, an exciting new multidisciplinary clinic for children, teenagers, adults who are overweight. It's family-focused. It's a clinic that brings together pediatricians, internists, and specialists who don't just do primary care but concentrate on weight management. In our public schools in 2007, the state of Florida passed a law requiring elementary students complete 150 minutes of physical education. They've modified that, unfortunately. At the start of the school year, though, Florida required that all middle school students have at least one class of PE daily for a full semester. So while all these initiatives and programs are excellent steps in fighting the obesity epidemic, we cannot stop there. It's critical that we need to do more, and I'll be very interested in your expert advice today. But let me just say, government cannot do this alone. Parents across this country have to take personal responsibility, and they've got to go to the grocery store and buy the healthy fruits and vegetables. They've got to fight for those supermarkets and markets in their neighborhoods. They've got to turn off the TV and tell their kids to go outside and play or do something constructive with their time. As co-chair of the Children's Congressional Health Care Caucus, childhood obesity has been one of our priorities, so I thank you, Chairman Pallone, again for calling this hearing, and I look forward to hearing from the witnesses. Hope that we can use this today as a step towards a broader national strategy to end this epidemic. I yield back.
Thank you. Gentleman from Ohio wish to make an opening statement? You'll waive? Okay. I think that concludes our opening statements. We'll get to our witnesses. And on our first panel, we have with us on my left Dr. William Dietz, who is Director of the Division of Nutrition, Physical Activity, and Obesity for the Centers for Disease Control and Prevention. And then next to him is Dr. Terry Huang, who is Director of the Obesity Research Strategic Core for the Eunice Shriver National Institute of Child Health and Human Development at the National Institutes of Health. And we welcome both of you. Thank you for being here today. You know, we have 5-minute opening statements that become part of the record, and then we'll move to questions by the members of the panel. We'll start with Dr. Dietz. Thank you for being here today.
Thank you, Chairman Malone and members of the subcommittee, for the opportunity to provide you with for statements on the record for today's hearing.
Is your mic on? You might have to bring it a lot closer.
Is that better?
Yes.
Okay, sorry. Thank you for the opportunity to provide this statement for the record on today's hearing on innovative practices to prevent childhood obesity. Mr. Chairman, you were correct about the prevalence data. 16% of 2 to 19-year-olds in the United States are obese, and an almost equal number are overweight. So about a third of our children and adolescents are obese or overweight. You also pointed correctly to the increased prevalence among certain subgroups of the population. So that, for example, in 2006, 27% of 6 to 11-year-old male Mexican Americans were obese, and 27% of 12 to 19-year-old African American females were obese. And although, as you correctly pointed out, we are at a plateau, an apparent plateau, that is not grounds for complacency. We need to invest in turning the corner on this epidemic, and we believe that just as the environment was the major contributor to this epidemic, the environment is where those solutions lie. Childhood obesity is associated with a variety of precursors for adult disease, namely elevated lipid levels, which predispose to hardening of the arteries, increased intolerance to glucose, which predisposes or is a precursor of type 2 diabetes, and elevated blood pressure. 70% of obese children and adolescents have at least one of those risk factors, and 40% have 2 or more. In addition, the persistence of childhood obesity into adulthood is associated with an increased risk of severe obesity in adulthood. About 50% of adults, half of all adults with severe obesity, namely 100 pounds or more of excess weight, had onset of this disease in childhood. So that even though childhood obesity contributes a minority of adult disease, it may have a disproportionate effect on the severity of obesity and its attendant costs and complications. 10% of the national health care budget is now spent on obesity and its complications, and that is a significant barrier to controlling the costs of our medical system. We believe that a multi-component, multi-sectoral approach is essential that focuses on policy and environmental change. There are at least 7 areas of interest. Pregnancy, excessive weight gain during pregnancy, type 2 diabetes or gestational diabetes during pregnancy, and tobacco use during pregnancy, all predisposed to early childhood obesity. We also believe that control is going to require an increased intake of fruits and vegetables, a reduced intake of high energy density foods such as fast foods, reduced intake of sugar sweetened beverages, reduced time spent viewing television, increased rates of breastfeeding, and increased rates of physical activity. Those are the target behaviors. Those are not the strategies that are necessary to implement those. So that, for example, with respect to increasing rates of breastfeeding, we need to implement policies and environmental supports in maternity care settings, implement the same policies and environmental supports in the worksite, and develop state and national breastfeeding coalitions to improve support for breastfeeding. Now, I'd like to turn to 3 examples, one in daycare or childcare, one in schools, and one in communities as examples of innovative strategies. One of the most innovative strategies is the New York City Group Daycare Initiative, which calls for the provision of no sugar-sweetened beverages for children in group daycare, limits to 6 ounces of 100% juice per day, 1% or low-fat milk for children over the age of 2, water available at all meals, increased rates of physical activity, 60 minutes, which is the requirement for children, and limits on television time. Now, the combination of these multiple targets and these multiple strategies in a daycare setting is likely to have a significant impact on the prevalence of obesity, not to mention the health of these children. A notable example of a school-based initiative has occurred in Mississippi, where 65 school districts have replaced deep fat fryers with oven steamers, thereby reducing the calorie and fat content of the food served to children. In addition, Mississippi has made major improvements in decreasing the availability of sugar-sweetened beverages and other high-calorie foods. They are now a leader in terms of school initiatives in the country. And then finally, with respect to community initiatives, the American Recovery and Reinvestment Act has allowed us to begin to invest in community and state-level changes that address these strategies. At the time of the Weight of the Nation, we released an MMWR, a Morbidity and Mortality Weekly Report, entitled Recommended Community Strategies and Measurements to Prevent Obesity in the United States. And these strategies focus on the increased availability of healthy food, decreased access to less healthful foods, increased access to recreation facilities, and increased physical education programs in schools. There are a total of 24 of those strategies, which we would be happy to share with you. In closing, children are our most precious resource, and obesity is a major threat to their health and to the costs of health care in the United States. We're seeing progress, but the opportunity now exists through the American Recovery and Reinvestment Act and other innovative programs to begin to reverse this epidemic. Thank you for this opportunity.
Thank you, Dr. Dietz. Dr. Huang?
Mr. Chairman and members of the committee, thank you very much for the invitation to testify today. I'm pleased to be here today to share with you some of our recent research and some of our plans for addressing this multifaceted problem as we move forward. The NIH recognizes that to really make a difference on childhood obesity, research should address the broader system in which children learn, play, live, and obtain health care. Such a systems-oriented framework will need to link biological factors of obesity with socio-environmental and policy factors that influence children's diet and physical activity. Over the last few years, research has demonstrated the important impact of the physical, social, and economic environments on the obesity epidemic. For example, neighborhoods with lower socioeconomic status have less access to safe settings for physical activity, which is associated with decreased physical activity levels and higher prevalence of obesity. Other community characteristics, such as the lack of public transportation or land use and zoning issues, can also contribute to decreased opportunities for physical activity. In addition, there's research showing that the availability of and access to healthy foods are important. Areas that are food deserts, or areas with a high density of fast food relative to other restaurant choices, are associated with a higher prevalence of overweight and obesity. Research has also shown that economic factors, such as food marketing and pricing, are critical as they can influence the purchase and consumption of nutrient-poor but energy-dense foods. To accelerate research progress and translate research findings into effective solutions, the NICHD, in partnership with a number of other NIH institutes and offices, the CDC and the Robert Wood Johnson Foundation, came together to form the National Collaborative on Childhood Obesity Research earlier this year. NCORE is designed to coordinate and synergize the funding efforts from member organizations to avoid duplication of efforts and to pool resources for large, ambitious projects that bring us closer to effective and sustainable solutions. For example, NCORE recently launched the Envision Project, which aims to help us understand the complexity of the childhood obesity problem and virtually test environmental and policy interventions through sophisticated computational systems models. NCORE will also soon begin funding a nationwide study to determine the effectiveness of existing community-based strategies and programs using a common evaluation approach. Some of those communities might be the ERA-funded communities that Dr. Dietz talked about, for example. In addition, a consortium of prevention and treatment trials that simultaneously target multiple settings in which children learn, play, live, and or seek health care will be funded this year. Other recent research programs of note include initiatives on encouraging community-based partnerships of obesity researchers with local or state-level policymakers, and research on school and community policies that impact obesity-related behaviors and outcomes. Funding received by the NIH under the American Recovery and Reinvestment Act has also created opportunities for innovative research. One NICHD example is a unique weight maintenance study with strong focus on children's social environment that aims to help children who have achieved weight loss to maintain their reduced weight. To conclude, it is important to note that the childhood obesity problem is linked not only to children's and parents' behavior, but also more importantly to social and economic development in a number of policy areas outside the traditional public health sphere. Thus, we need to deal with obesity as a systems issue, not just a health issue. We need to invest resources into research that is systems-oriented, multi-level, and cross-disciplinary, and include partners from all sectors of our society to generate effective and sustainable solutions. The solution to the childhood obesity problem will require a coordinated, collaborative, and multi-sectoral strategy that includes strong actions from the government, industry, community, and family. Together, we need to create an environment that not only favors trade and economic productivity, but it also takes into account the long-term health of the population. Until both healthy eating and physical activity become naturally embedded in everyday life, there is little chance that the childhood obesity toll in the U.S. and around the world will diminish. Thank you. I'd be happy to answer any questions.
Thank you, Dr. Huang. And now we'll have questions from the panel. I'll start out by recognizing myself. You know, what I'm going to say, I guess, is kind of a cliche, but I love to use stories or personal, stories to sort of make a point when I can. What you said, Dr. Huang, and I totally agree, is that, we need strong action. But the question is, a lot of these things are so personal in nature, not necessarily viewed by the American public as something that the federal government gets involved in. So I guess my question always is, to what extent can the Congress legislate or provide funding that's meaningful? And let me just give you my story. I always think about my grandparents because they were Italian-American immigrants, and they came from Italy. And my grandfather, who lived to be, I think, 96 or 98, was always thin. And he would literally have a garden in the backyard, raise the things that he would eat, not completely, but a lot of the stuff. My grandmother would can the goods, put the tomatoes and the peppers and everything in jars. I mean, so much of what they ate was just grown by them in their backyard. And then they would, even in the winter, they'd have it because they'd can it or whatever, preserve it. And, they never went out. I remember my grandmother, had an aversion to ever going out to a restaurant. I can never remember her going to a restaurant ever, or doing takeout. I mean, I don't even know if it existed then, but it just didn't occur, okay? Today it's just the opposite. When I go home, we're always looking to go for takeout. The kids, I have teenage kids, they're always looking to go to McDonald's. It's just the whole nature of a lifestyle has changed. And I was mentioning Native Americans. One of the highest incidents of diabetes is with the Pima people. And I've been out to the Pima Reservation, to the Tohoto O'odham in Sells, Arizona, which is another Pima people. And, that's where I would see every year that I would go, there would be lower and lower the kids would get, diabetes at a younger age. And what they would tell me was that, historically they were a desert people. They would gather in the desert everything they ate. It was a very different diet. Now they're eating all processed foods. Now, one of the question really is, we can't go back. I mean, you're not going to take people back to the old days. Is there things that we can do now, though, that, recreate that? Like, for example, with the Tohoto O'odham, it was suggested that they start like a vitamin supplement program. And then there was a nonprofit called TOCA, T-O-C-A, that started trying to get people to grow some of the traditional foods through a local cooperative. So that, I just example, we can't go back to what life was like 30, 40 years ago, when maybe people were healthier in terms of what they ate. But on the other hand, what's the role of the federal government? Because so many of these things are personal. They're not necessarily, it's lifestyle. I know it's a broad question, but.
Well, thank you for your question and comment, Mr. Chairman. I think your point is well taken. I think research has clearly shown that along with the social and economic changes, as you have mentioned, many aspects of our lifestyle have changed, and many aspects of our environment have changed to result in the lifestyle that we have today. So I think what the collection of research is suggesting is what we need to do is to really somehow think about making the environment conducive for people to have healthy eating and physical activity habits. So I think in a way you can think of it as giving people, the full gamut of choices so that people can truly exercise personal responsibility. If families don't have access to healthy foods in their neighborhood because there's no supermarket or there is a lack of variety of food outlets, then they don't really have the option to even exercise the full range of personal choice. So
Well, that goes back to the other thing I mentioned. When I was growing up in the neighborhood where my father still lives and where our congressional office is, there was a school that had a playground. The school closed, no playground anymore. The Y closed because they didn't have enough money. And, that's what's happening. In a lot of the urban areas or poor areas, and this isn't really a poor area. I mean, I'm not suggesting that, but it's not a high-income area. A lot of the nonprofits and the educational institutions that had these recreational opportunities have sort of dried up for lack of funds. They're more likely to build a Y in a suburban area than they are in an urban area. At least I've never done a survey, but it seems that way.
Yeah, I think there are a lot of promising actions that are taking place on the ground right now, and I think our second panel will illustrate some of those very promising approaches. Reintroducing food to areas where that are considered food deserts right now, for instance. I think we're going to hear from someone from Pennsylvania later today on that issue. Right in D.C., you see a resurgence of neighborhoods, increased mixed land use, so people are, walking more, engaging in more physical activity. These are all, I think, really promising ideas that are in keeping with, advancing modernity and advancing progress, but at the same time, building back physical activity opportunities and healthy food opportunities back into our daily lives. And I think these are promising opportunities. We definitely need to do more research. We need to monitor and evaluate what effects these changes will have on people's behavior and health outcomes. But I think that there are promising solutions that are already taking place, and there's a lot, that I think all sectors of society can do, from government all the way down to the individual family and children.
All right, thank you. A gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman.
You still have I've been in your district, you still got a lot of farms and healthy foods there.
Farmers markets and a lot of canning. The Amish Mennonite do a lot of that. With unanimous consent, I'd like to submit my opening statement for the record. Thank you. Dr. Dietz, in your testimony you mentioned that the obesity trend is leveling for boys and girls ages 2 to 19. What factors do you think are contributing to that leveling?
I wish we knew with some specificity.
Maybe it's a good time for me to mention that we're going to have 4 votes, but I want to try to get a couple more questioners in before we break.
Sure. I wish we knew with some specificity what was accounting for the plateau. By way of analogy, what we saw with tobacco was a steady acceleration of per capita tobacco use until awareness began about the adverse effects of tobacco, at which point cigarette smoking began to plateau. The attention given to obesity in the press recently and at all levels of government, I think may have increased awareness of the adverse health impacts of obesity and changed behaviors in some ways that we don't yet understand clearly. The other major development has been in schools, that our Division of Adolescent and School Health has shown very substantial changes in the reduction of the availability of unhealthful foods in schools, which may have also been an important contributing factor. But it's important to emphasize that all we have is a plateau. We don't yet have in place the kind of environmental and policy initiatives that drove tobacco in the other direction. And those are the areas that we think we need to invest in with respect to obesity.
In your testimony, you mentioned that communities putting prevention to work program. Can you elaborate further on this program? Has the program begun?
Sure. These are the American Recovery and Reinvestment Act funds that came to CDC for community and state initiatives. We've received a very large number of applications from both states and communities to address either obesity through nutrition and physical activity strategies or tobacco or both. I wish I could provide you with details about how those applications are distributed, but we see those as the most promising investment in understanding what works at the community level. And that this, in my testimony, I included an outline of the target behaviors and some of the strategies that we think are necessary to accomplish those changes. And those initiatives or those suggestions have been shared with the communities applying for these funds, and we expect those states and communities to implement these strategies. That'll give us an opportunity to understand the intensity of the interventions necessary to control obesity and the combination, perhaps, of those interventions.
Thank you. Dr. Huang, in your testimony, you mentioned the Envision Project, funded at $15 million, and the project aims to, quote, understand the complexity of the childhood obesity problem and virtually test environmental and policy interventions through computational systems models. Can you elaborate a little bit on that?
Sure. So this is a very nice example of cross-disciplinary, transdisciplinary research where those of us on the public health side have begun to learn a lot about methods used, for example, in engineering, in computer science, where computational techniques to integrate very, very large and complex sets of data simultaneously can be applied to very complex public health problems, such as obesity. And as we mentioned here today, obesity results from a wide range of etiological factors. And research to date hasn't really been able to integrate all that information simultaneously in analysis or design of interventions. So the idea of the Envision Project is to capitalize on our current computing power to try to piece together the different aspects of the obesity puzzle, but at the same time to help us play with different intervention techniques that are perhaps expensive and difficult to implement because they're at a more macro level, such as environmental modifications and policy changes, and to help us, anticipate what are some of the intended and unintended consequences of those interventions in a virtual environment. And that information should provide great insight into what might be effective or not, and in what context, before we go out there and implement some of these large-scale interventions. So similar work has been done, for example, in infectious disease areas. The U.S. government already uses a lot of these systems models for the control of the flu epidemic, for example. And I believe that a lot of that work has been extremely insightful. And we anticipate similar success with the Envision Project.
Thank you. My time has expired.
Thank you. We have 9 minutes left, so I want to at least get one more speaker in. And Mr. Murphy is next.
Thank you very much, Mr. Chairman, and thank you for this hearing. I think an incredibly important subject, having been the chair of our state, Connecticut's Public Health Committee in the state legislature. We tried to deal with this issue on a number of levels, and I'm glad to see some attention being focused here. Let me just open up one subject, knowing that we're short on time, and I'll ask you both to comment on it. My district in northwestern Connecticut reflects the diversity of living patterns throughout this country. I've got quintessentially rural areas, I've got suburban areas, and then I've got some urban centers. And it strikes me that we need different tools and we face different challenges in each one of those settings. And so I just want to ask you particularly about that urban setting and about the particular challenges presented to families and kids in urban centers where even if you make a decision as a family to eat more nutritionally, you have a harder time finding that kind of food that creates the kind of nutritional lifestyle that we're putting forth with these new policies. And second, with regard to exercise, kids are in schools that don't have fields. They have to travel a distance to find any type of open space to run around and play football and baseball on. And I wonder what you see as the particular challenges and maybe the particular policy responses that we need to attack some of the specific challenges that inner city and urban kids are facing today.
In my testimony, I indicated the publication of an Sorry, thank you. In my testimony, I pointed to an MMWR, Morbidity and Mortality Weekly report that we published in July, which began to outline strategies for the implementation of better food, increased physical activity in communities. One of the major problems which you've pointed to is access. And we think that programs like the Fresh Food Financing Initiative in Pennsylvania, which builds supermarkets in underserved areas, are a model that we ought to point to and try to implement more broadly. Access is also a factor affecting recreation facilities and parks for physical activity of children and adults. How one accomplishes that is less certain, and that's, again, I think the funds that we have through ARA give us an opportunity to understand those challenges and the impact of making changes in those arenas.
So, right, the problem is Stop and Shop and Whole Foods, you know, they're not going to go into those areas because they just don't see a market for it. And so you can either work over a period of decades to create the demand and hope that private sector capital follows demand to put those type of full-service grocery facilities in those neighborhoods, or maybe you're suggesting, as Pennsylvania has done, you actually put some government money behind the financing of those inner-city fresh food facilities or full-service grocery facilities?
Right. I'm not an expert on the Fresh Food Financing Initiative. I think it's a mix of private and public funds. But yes, and that can be done on a variety of scales. It can be done by putting a supermarket into an underserved area. In New York City, Dr. Frieden had a bodega initiative, which provided loans or access to facilities for keeping fresh fruits and vegetables cold, implementing a low-fat or no-fat milk campaign in those stores. So there's, but what we don't understand yet is what the impact of those types of initiatives are on food quality and food intake.
Dr. Huang?
I would just concur, and I think the congressman points out, sort of the crux of what we're talking about in terms of really making the environmental changes, that would be conducive, to having people engage in healthier eating practices or physical activity. Without those options, people can't have the full range of choices. I think that some of our recent research, with NIH, CDC, and Robert Wood Johnson Foundation and other funding organizations is hoping to evaluate the effectiveness of various community-level strategies. I mentioned earlier in my testimony that we're about to launch a nationwide evaluation with a nationally representative sample of communities using different approaches, and hopefully in a few years we'll have some good data to point towards what might be effective and what might be sustainable. And I think the sustainability aspect is a really key thing. And some of the things that we may need to do in terms of solution, are putting in place, the seed for long-term change. We're not going to solve the childhood obesity problem overnight, and I think we need to have our, eyes set, on a long-term trajectory and putting in place measures that will get us to where we want to be, down the road, not just for the current generation, but for the next generation.
Thank you very much, Mr. Chairman.
Thank you. Now we have 4 votes, which could take us maybe a little more than half an hour, but we'll try to get right back. And we'll still have some more questions of you before we go to the next panel. So the committee stands in recess.
That's right. How are you? Hey, Brad, nice